Okay, நம்ம இப்போ Bartter Syndrome பற்றி பார்க்கலாம். Bartter Syndrome is an autosomal recessive disorder which is having a neonatal onset and it can also have a prenatal onset. So, எங்கே defect இருக்குன்னு பார்த்தோம்னா, it is the defect in the sodium potassium 2 chloride co-transporter located in the thick ascending limb of lupus limb. So, other name சொல்லி பார்த்தோம்னா, it is a salt-wasting tubulopathy in the Henle's loop. So this is the normal nephron and this is the thick ascending limb of lupus Henle and the sodium potassium 2 chloride co-transporter is present over here. Let's have a closer look. This is the thick ascending limb of lupus Henle. This is the basolateral side and this is the apical side. Apical side we have our co-transporter. When this co-transporter is normal, there's going to be reabsorption of sodium, potassium and 2 chloride ions from the tubular fluid. So normal இருக்கும்போது this is going to cause an osmotic gradient. This osmotic gradient is going to drive this calcium and magnesium ions from the tubular fluid through a paracellular transportation. So in the channel work anada the paracellular transport will also take place. So in our patient there's going to be defect in this channel. So there's going to be increase in sodium, potassium and chloride ions in the tubular fluid. Also there's going to be increase in calcium and magnesium ions. Since the sodium is going to increase in the urine, this is going to cause polyuria because sodium is also going to take water along with it. Because of this polyuria, there's going to be a slight decrease in plasma volume which will cause increase in renin, which in turn will cause increase in aldosterone. Aldosterone increase agadanaala it is going to act in the collecting duct in the basolateral side. It is going to cause increase in the epithelium sodium channels which will cause increase in reabsorption of sodium ions. So over positive charge of ion is reabsorption agumbod there must be equivalent positive charge loss which is loss in the form of potassium and also in the proton ions. Idanaala there is going to be hypokalemia and also metabolic alkalosis. One small concept we have to understand is regarding the juxtaglomerular apparatus. In the juxtaglomerular apparatus located over here, this is the afferent arteriole and this is the distal convoluted tubule. Normally, there is going to be sensing of sodium through the same channel which is defective over here. Because there is loss of entry of sodium ions in the juxtaglomerular apparatus, this juxtaglomerular apparatus is going to produce prostaglandins. This prostaglandins will cause dilation of afferent arteriole which will cause a slight increase in GFR. Prostaglandins increase agadanaala we can see there is an increase in prostaglandins in blood, also in urine. So now let's go back to our first slide. நம்ம என்ன பார்த்தோம்னா there is defect in this co-transporter which is going to cause polyuria along with renal salt wasting. Because there is salt wasting, there is decrease in plasma volume which is going to cause increase in plasma renin and aldosterone. Aldosterone is going to cause increase in sodium reabsorption in the collecting tubules which is going to cause potassium loss and also hypokalemia and proton loss which is going to cause metabolic alkalosis. Because there is loss of calcium in the urine, that is hypercalciuria, there is going to be presence of renal stones. So other than that, the BP of the patient is going to be usually normal. In some patients there can be a slightly lower BP. CNS symptoms pathoma, there is going to be developmental delay, mental retardation, seizures and paresthesia. And there is also going to be a generalized weakness because of hypokalemia. Because of polyuria, there is going to be dehydration and some patients can also have fever. Prenatal manifestations in Bathomna, when there is prenatal Bartter, there is going to be fetal polyuria which is going to cause polyhydramnios and this can lead to premature delivery. So let's have a look at the laboratory abnormalities. So there is hypokalemia, increase in plasma renin and aldosterone, and there is increase in plasma prostaglandin levels which in turn cause increase in urine prostaglandin levels. So there is also hypercalciuria. So how are we going to manage this patient? So we have to manage the dehydration and electrolyte loss by fluids and electrolytes. And the other drugs used are the ACE inhibitors and spironolactone. Spironolactone will preserve the potassium, and NSAIDs, which is going to inhibit the prostaglandin. Most preferred NSAID is going to be the indomethacin. And this is all about the Bartter syndrome. Thank you.